So I'm going to start my session then. With this picture. This is where it started for me. Some years ago, I was asked to give a talk on an elderly patient with iron deficiency and normal endoscopy and what we do with that patient at gastroenterology. The idea here, or the idea of the picture and why it was so impactful for me, is that it captured the essence of how a patient struggles with iron deficiency, particularly somebody with a vocation, like in this case a nun, getting to do everything, but yet in pallor, in fatigue, nodding off at inappropriate time, very non-specific symptoms, not enough to ask of the person to resign their profession or their vocation, but just making life difficult for that person who's suffering iron deficiency. And often, and sadly, many patients go on like this to struggle on, get by in the day, taking years before being helped for this calamity called iron deficiency. So along the way, and as my journey with this topic went, I was asked to be part of the team and to looking into the guidelines or guiding gastrointestinal evaluation and management of iron deficiency in South Africa. And this expanded to sub-Saharan Africa. And this has been quite an experience, very rewarding experience for me, together with 20 other colleagues from sub-Saharan Africa. And we, through a Delphi process, set up a number of consensus statements which guide gastrointestinal evaluation and management of iron deficiency in sub-Saharan Africa. And this was published in the beginning of this year. So we're very happy with this document, and it's guiding practice in our setting. So why this is important for this discussion is I've used the same ideas in the document to premise many of the discussions and points I'd like to make with regards to gastrointestinal wellness. And I think that was a handy way for me to guide me through in the preparation for this discussion this evening. But please feel free to take a link to the document, and I'm sure you'll find it fruitful in your practice wherever you are. So just some background, as you know, or as you may have already know, over 30% of the world's population is anemic, according to the WHO in 2023. The figures: 40% of all children aged 6 to 59 months, 37% of all pregnant women, 30% of all women 15 to 49. And of all these, the most common nutritional cause of anemia is iron deficiency. If you look at iron deficiency specifically, it occurs in 2 to 5% of adult men and postmenopausal women in the developed world, and it's a common cause for referral for gastroenterological investigation. And in investigating these patients, we look for gastrointestinal blood loss, mainly to make sure that they're not from malignant source, and then malabsorption from a myriad of causes, these being the most important things that need to be sought in patients with iron deficiency, and what was the stemming for the guidelines that we brought about at the beginning of this year. It's a major burden worldwide, and this slide shows that South Africa, sub-Saharan Africa, is really burdened by anemia, and the bulk of this then being iron deficiency. Interestingly, when you look at the proportion of the prevalent cases, and I had a discussion recently with a colleague in Austria at one of the meetings, one of the anemia meetings that I was privileged to attend. And I asked him simply, I said, in your practice, what is the main cause of iron deficiency? And he actually shocked me by saying that it's actually malnutrition. I said, what do you mean? I thought Austria was a first world country and you were far ahead of the developing world. And he said, no, malnutrition doesn't only affect the developing world, and affluency or affluent populations are just at risk of iron deficiency due to issues of obesity and malnourishment, but also poor eating habits of people in more affluent populations. So this data then demonstrates this with even in high income settings, dietary iron deficiency being the bulk of causes contributing to anemia in populations around the world. So an extremely relevant problem that spares nobody. The causes then we divide fancily into 4 groups. So lack of dietary iron, improper nutrition, copper deficiency, with copper's role as its center of festin, which is important. We'll get to that in the absorption part of this discussion. So if you have copper deficiency, that could lead to iron deficiency. Eating disorders, people who are vegans or vegetarian in diet, decreased absorption with gastrointestinal inflammation, like in inflammatory bowel disease, gastrointestinal infections, bacterial overgrowth, achlorhydria, either because of autoimmune disease, resection of the stomach, of the antrum, or something common that many of you prescribe is PPIs, acid suppressants. And we often underestimate the acid suppressant and its role in absorption and in inhibition of absorption. And iron, of course, requiring acid as an important step for its absorption. The PPIs impede this. Altered iron utilization, and this would be seen in physiological altered states, like in pregnancy, but also abnormal states like chronic infections, chronic disease, malignancy. And then, obviously, important to us at gastroenterology, the search for blood loss. So patients with inflammatory bowel disease who are bleeding, especially ulcerative colitis, other gastrointestinal losses, peptic ulcer disease, polyps, diverticulosis, angioectasia, heavy menstruation, and other bleeding diathesis. So multifactorial reasons why a patient can be predisposed to iron deficiency, and things that should be sought out in any patient presenting with the deficiency. In finding the patient, I think all the signs have been discussed very clearly in the sessions before me, but this slide just highlights that many of the symptoms and signs are gastrointestinal in nature, and those being angular stomatitis, glossitis, the thick, painful tongue, dysphagia linked with esophageal webbing. Pica is then a gastroenterological or gastrointestinal symptom, with people eating soil, geophagia, ice, pacophagia, and a myriad of other things that people have listed that they eat or consume. Interestingly, nutritional things or very sweet things, very salty things. I had a lady the other day that was eating buckets of mushrooms, raw mushrooms, daily. So one should just have a high index of suspicion when you get someone that is selected either a certain food group that's odd or something non-nutritional that they eat excessive amounts of. Splenomegaly, it's interesting. And the theory behind this, or the idea behind this, is that it is one of the extramedullary hematopoietic reasons for splenic enlargement due to the bone marrow effects of the iron deficiency. And then obviously, once a patient decompensates, the cardiopulmonary disease that the patient would then have would also influence the gastrointestinal tract and lead to things like cardiac cachexia, impaired eating, early satiety, and so forth, which would all play a role in contributing to the gastrointestinal symptoms and signs that these patients with iron deficiency may have. Very fancily, and I'd like to think from the gastroenterological point of view, the center point for me with regards to regulation of iron, I like to believe, is the enterocyte. I tried to look at the enterocyte earlier today, and interesting that I've never calculated how many enterocytes there are in the human body, and I couldn't find a figure. You have about 6 to 7 meters of a small bowel, and the enterocyte, the figure that is published is that it is 80% of all the epithelial cells in the 6 to 7 long meter small bowel, which serves for absorption of a myriad of nutrients, trace elements, and the like. And an important compound being iron has its own very fancy way of being taken up, intestinal absorption, but intriguingly also regulation of iron intestinal transport. So if we look at the epithelial border and you see that you have dietary non-heme iron or ferric iron, which is reduced by the actions of ferric reductase or cytochrome B, and reducing agents in the diet like vitamin C, also with hydrochloric acid in the stomach. This ferrous iron enters the enterocyte via the divalent metal transporter 1, and in the enterocyte, together with the heme iron from broken down heme by heme oxygenase, this heme iron, which is also liberating ferrous iron, joins this intra-enterocyte pool of iron, which much of it is then stored in ferritin as Fe3+, but then a lot of it goes into this labile iron pool, or the LIP. Should there be a sensing that there's adequate iron, and we'll get to that shortly, this then can be sloughed off in this enterocyte, and that's a means of regulating iron. But if then iron is to be taken in, it is taken in via the IREG, or the influx pump on the basolateral membrane as Fe2+, and then by hephaestin changed into Fe3+ again to board the transferrin molecule to then internally serve its purpose wherever it may go. And I think this has been discussed at length in the sessions by Prof. Lowe and the team with regards to iron and its journey from then on. But I'd like to get back to the enterocyte, being it gastroenterological, and just emphasize something that these authors, Sharp and Sry, call the duodenal crypt villus axis, which represents a pathway that is influenced by both the dietary signals as well as internal humoral signals to influence genetic transcription of the mechanisms to iron absorption. So these immature proliferating cells in the crypt take up transferrin from the circulation via the transferrin receptors, and through this process, they are able and are sensitive to the circulating levels of iron and iron saturation in the transferrin molecules. And these iron regulatory proteins recognize the iron content and then regulate the response by influencing mRNAs post-transcriptionally. So in addition to this, there's a number of humoral factors, both hepcidin from the liver and then cytokines interacting from all their individual specific receptors. And together, all these processes set a basal level of iron transporter expression at the enterocyte level. So it just emphasizes the role that the enterocyte plays in the regulation of iron and the combination of this basal programming, fine-tuning the iron absorption based on the availability of iron on the luminal side of the enterocyte and the saturation of iron on the basolateral side of the enterocyte. And I find this very intriguing that this sits within this very small cell called the enterocyte in the small bowel, this sort of grail of a place, holy grail of a place, guarded by the pylorus and the terminal ileum at the end of the small bowel. So it's something very fancy to me, and particularly with regards to iron in the first part of the jejunum and the distal duodenum, where this fancy physiology is taking place. So the enterocyte and iron absorption is crucially important. The document I mentioned earlier was the guidance document, and the areas I'd like to touch on are stemming from that document. And we gave a number of general recommendations in practice. We spent a lot of time on Helicobacter pylori, celiac disease as a surrogate for malabsorption, bleeding, especially patients who have difficult bleeding that are not evident on initial gastroscopy or colonoscopy, inflammatory bowel disease, patients which many of you will see and refer, and many gastroenterologists will then take hold of and try to assist. Preoperative care, the physician and the doctor always plays a role in optimizing a patient for an operation, and I think the iron deficient patient, this has been shown through previous sessions by Dr. Gibbs as well, and I'm not going to dwell too much on perioperative care here, because that was dealt with quite nicely there. And then the culmination, the end of the document looks at iron replacement therapy. I'm going to touch on a few points there with regards to gastrointestinal milieu as well. So iron deficiency, we viewed when constructing the document as a ferritin level below 30 nanograms per mole. And it was said that if a patient was found to be iron deficient, that gastrointestinal investigation should be considered in all these patients. It's always amazing to me that when I see a new group of students, I spend a lot of time with them at our university, and you ask them, what are the symptoms of iron deficiency? 9 times out of 10, many of them will report the symptoms of anemia. And likewise, they continue to search for patients who are anemic before they exercise any caution or urgency in those patients. And the whole drive is that gastrointestinal investigation should be considered in patients with non-anemic iron deficiency as well. So much so, if you'd look carefully, you'd see that the title of the guideline or the guidance document does not have anemia actually in it. So the idea here was that we should be moving from anemia and its evaluation, which is actually the last step of iron deficiency, to picking up patients early on with iron deficiency and evaluating them to pick up their problem or their cause of the blood loss or their anemia early, and not push them down this path of developing anemia and all its deleterious sequelae before we are alerted to their send them for investigations or work them out. Should you then refer a patient, the decision to perform the initial sequential, in other words, initial gastroscopy and then colonoscopy, or doing both at one setting, should be decided upon by the clinician, or in this case, the gastroenterologist, the physician, or the surgeon. A lot of discussion about premenopausal women with iron deficiency. Historically, everything for iron deficiency attributed to menopause and heavy menstruation. But it's shown that in this group, these young ladies often should also be offered upper endoscopy and iron replacement, and then further investigation should be taken out should they not respond to these 2 interventions. And very importantly, while the gastrointestinal tract is an important place for intestinal blood loss, it is paramount to remember that there are other areas where, or potential sources that one can lose blood. And this would be in the genitourinary tract. So always look for hematuria, patients who are coughing from cavitation in the lung. So think about a chest x-ray, think about symptoms, respiratory symptoms. So think about other potential sources. Patients with epistaxis chronically often bleed into the GI tract. And then you scope the patient and there's nothing in the stomach. And then the patient comes in again, only to find that this is epistaxis, which the patient is swallowing and then vomiting. And then, and rarer things like hemosuccus pancreaticus or bleeding from the pancreas, you wouldn't see on gastroscopy because the patient would have been fasting. You give the patient secretin, or you administer something, or you sit next to the ampulla of vata and suction a bit, and then you see the blood coming out of the pancreatic duct. So there are many other sources, some of them easy to identify and some of them a lot more obscure to identify, that should be considered in patients with iron deficiency. No gastrointestinal discussion about iron deficiency is complete without touching on Helicobacter pylori. And for me, Helicobacter pylori serves as the surrogate for the myriad of microbiota and massive world within us, which is the microbial entity that we all have within us, and the influence that it has on absorption, on health, and absorption of specific nutrients like iron. And I think Helicobacter pylori itself is linked and is studied very extensively in the Maastricht criteria, and they see it as a cause for unexplained iron deficiency, so much so that if you have a patient with iron deficiency, it's not wrong when it's suggested that you can non-invasively test them for Helicobacter pylori, and if the non-invasive test is positive, you could then treat them or eradicate them, and your iron deficiency would improve. Moving down to Africa, we have a very high prevalence of Helicobacter pylori, which in studies is as high as 70 to 70.1%. And there's this clear association between Helicobacter pylori and iron deficiency anemia. In patients with unexplained iron deficiency, those that coming to us, we always do invasive testing, those that come for gastrointestinal investigation. So we use a rapid urease test, or where that's not available, histopathology, which is time consuming often. But the standard currently is to do a rapid urease test, biopsy in the antrum, biopsy in the corpus of the stomach, and both these samples are put into the rapid test, and it gives you an answer immediately. There are a number of non-invasive tests, urea breath test or stool antigen test. The urea breath test is not freely available, and the stool antigen test is the one that we are using currently. Very importantly, and important to note, is that should you eradicate a patient for Helicobacter pylori, the eradication should be confirmed. And the test, or the preferred test for confirmation of this eradication, is the stool antigen test, which is available widely. So the patient that responds to Helicobacter pylori eradication and that responds to the iron deficiency may respond, but not respond in terms of the malignancy risk that H. pylori often predisposes a patient to, especially the corpus predominant H. pylori type of infestation. So one should always make sure, because this stimulus for lymphomatous malignancy would be ongoing in the asymptomatic patient. And we want to confirm that H. pylori has been eradicated. And any patient that gets a 2-week course of eradication therapy, that suggested standard therapy would be 2 antibiotics and a proton pump inhibitor at full dose twice daily. And the standard triple therapy regimen that I've put up that we are using is amoxicillin 1 gram twice daily, clarithromycin 500 milligrams twice daily, and whichever proton pump inhibitor you prefer, to use that at full dose twice daily for the 14 days. Those that are allergic to penicillin, you can use metronidazole at 400 milligrams twice daily. And important to note that this is a finite course. You stop the therapy after this, the H. pylori have been eradicated, and then you observe your patient. In the guideline, it was decided, or on consensus, that oral iron should be introduced after completion of eradication and not with the eradication therapy, due to gastrointestinal side effects and compounding of these side effects. And there's not much loss to eradicate and then to start your oral iron, should you be using oral iron, that is, in a patient that you need to replace. And then I've alluded to this idea that you have to confirm the eradication of Helicobacter pylori infection using a non-invasive test. Celiac disease is an extremely good example of malabsorptive cause of iron deficiency anemia. We're fortunate that we don't see many patients with celiac disease. They do exist in South Africa, but not common. But in those patients with celiac disease, iron deficiency is a cardinal feature of their presentation and occurring in up to 50% in some studies. So this is a condition where you have a response, an immune response due to a genetic predisposition, and it's a response to gliadin proteins from wheat that triggers an immune response, an antibody release and T cell migration towards the enterocyte brush border, and you get this antibody mediated together with T cell mediated lymphocytic infiltration, and then the subsequent atrophy of your absorptive surface area, leading to a luminal malabsorption. And then because this affects the distal duodenum or the duodenum as well as the proximal jejunum, this is the area where iron is absorbed, and this renders a patient unable to absorb iron. And typically this is a young female, Caucasian in ethnicity, who then presents with abdominal pain, failure to thrive or weight loss, and iron deficiency, and this should be considered in this setting. Initial serology with the anti-tissue transglutaminase antibody, which is the IgA antibody, should be followed by small bowel biopsies in those who are found to be positive, have positive serology, and this biopsy is confirming the condition. And the treatment here would be strict gluten-free diet and iron replacement therapy, of course, initially intravenously because absorption is difficult. But once the patient reconstitutes their villi, and you see this on follow-up and on follow-up biopsies, you could then switch over to oral iron, which would help these patients. Importantly, that this is a autoimmune disease, and one should survey for the accompanying diseases that also go with other autoimmune diseases, as they often do: adrenal disease, diabetes, thyroid disease, and a very symptomatic itchy rash called dermatitis herpetiformis. One of the areas which we deal with at gastroenterology is patients who are bleeding. And if you do an upper endoscopy, that's fine. You find the cause of bleeding, that can be addressed, and we have a myriad of ways in which we address those. You do a colonoscopy, you find the source of bleeding. But what happens when the upper and lower endoscopy are normal? We call that obscure gastrointestinal bleeding, and that can be divided into overt, which is where the patient is exsanguinating and bleeding overtly. That patient usually goes to surgery, or the patient is presenting with occult, or what we call suspected small bowel bleeding, where the bleeding is assumed to be between the ligament of Treitz, or the distal part of the duodenum, and the terminal ileum, where we go from lower endoscopy. And you suspect that there's small bowel bleeding. And in patients with this normal upper and lower endoscopy, we advise an initial trial of iron supplementation therapy with good follow-up. And if the patient then remains refractory, we would then go on to do a video capsule endoscopy, which would then look at this area in between. What we found here, fancily, is that if you give a patient an intravenous iron repletion and follow them up, the patient who responds to the intravenous iron repletion is almost confirming that the cause is actually a malabsorptive cause, the one that responds. If you give a patient iron repletion, complete iron repletion, and you follow them up and they've dropped after 6 to 8 weeks on follow-up, and they are still iron deficient, or they are the same, or they are worse off, then you could pretty much confirm for yourself that this is a loss. And that would be more motivation to then look in between and to do relook endoscopies and further investigations into finding the loss of iron in that patient. Inflammatory bowel disease is an important condition that we should not miss, and particularly with regards to iron deficiency and anemia. We know that anemia is the most prevalent extraintestinal manifestation of the various types of inflammatory bowel disease, but the cardinal ones are Crohn's disease and ulcerative colitis. There's many other forms of inflammatory colitides like microscopic colitis, lymphocytic colitis, collagenous colitis, which to varying degrees present with anemia and iron deficiency, or iron deficiency with or without anemia. What we see with IBD-associated anemia is that this is due to a combination of iron deficiency and anemia of chronic disease. And the cause of iron deficiency then is multifactorial in the setting of iron deficiency, inflammatory bowel disease. And I think it's what makes this such a sinister thing in these patients, because they have blood loss from ulcerated mucosal surfaces, they have decreased dietary intake, they have malabsorption, especially those with Crohn's disease, and the chronic inflammatory state, as I've alluded to in the discussion with the enterocyte, and this cross-play with the regulation of intestinal iron transport. The chemokines that are in excess, like anti-TNF, interleukin-6, and so forth, are all making iron transfer difficult, with iron transfer block and so forth. So all patients with inflammatory bowel disease, when crossing your path, anemia and particularly iron deficiency should be top of the list in terms of your surveillance, and these patients should be assessed for and managed aggressively. Our guideline gives good information of how to do this and to support these patients, and also emphasizes the need to monitor them serially as you continue to follow them up in your practices, wherever that may be. Irritable bowel syndrome is interesting. I've touched on it here because we do get the discussion or the question about these patients. And, can irritable bowel syndrome or IBS cause iron deficiency? So this is a separate entity. This is not an inflammatory entity. It is defined in the Rome 4 criteria as the presence of abdominal discomfort or pain that is associated with disturbed defecation. These patients struggle significant bloating and abdominal distension, and the pain improves with defecation, and there's a change in the frequency and the change in the form of the stool. So you could have a patient with IBS or irritable bowel syndrome with diarrhea or constipation or an alternating pattern. And these patients are really having difficulty in terms of quality of life. And the question is iron deficiency playing a role here? And I take this to this work, which was done by Shea about irritable bowel syndrome. And in any article that you read on irritable bowel syndrome, you will see that there will be lists of things to say when it is not irritable bowel syndrome. And I think I'd like to use that to emphasize that if we shouldn't be viewing irritable bowel syndrome patients as at risk for iron deficiency, and we should view iron deficiency in a patient with IBS as an alarm that it's actually not irritable bowel syndrome. So I think this message should be very clear that iron deficiency, with or without anemia, serves as an alarm symptom together with these other lists or alarm symptoms that we use as cautions in patients with IBS to prevent us from making or to hinder against making this diagnosis, and then to evaluate patients for more sinister reasons for the symptoms that they may present with. So it's a very important point that IBS does not directly cause iron deficiency, but if you read the literature, you will see that patients with IBS may be more likely to follow restrictive diets because the treatment of IBS often entails restricting diet, and then this may lead to nutritional deficiencies. So I think there may be some association, but IBS per definition is not causing iron deficiency. And then lastly, just to talk about iron replacement, I think the idea is to restore normal circulating hemoglobin levels, replenish body iron stores, improve physiological functioning, and ultimately improve quality of life. And this rings true in gastrointestinal health as well. So the traditional oral iron salts, ferrous sulfate, ferrous gluconate, and ferrous fumarate remain the standard therapies. In the state sector where I work, ferrous sulfate is what we have. It is inexpensive, effective, and safe, but problem is side effects: abdominal discomfort, nausea, staining of the stool, constipation mainly, but patients can also have diarrhea. So we are using lower doses. This has been discussed extensively as well in previous talks. Infrequent administration every second day, taken on an empty stomach. Our guidelines suggested that vitamin C co-administration is not recommended, and the dietary vitamin C should be adequate to help with this initial transfer from ferric to ferrous formation of iron before absorption. The newer sucrosomal and ferric formulations are as effective as oral traditional iron salts that I've mentioned. Their advantage, though, is that they are more tolerable. And in terms of the side effects, they can be given daily with very good or equivalent absorption, and then with much less or much more tolerable side effect profile than the traditional iron salt. So this is their benefit. Cost is a hindrance, obviously. And then we hope that these agents will be more freely available to larger groups in the future. Modified release formulations are not advised because they release iron distal to the areas of most active assimilation. And I don't think in the literature that it's demonstrated that they've got enhanced absorption or any reduction in side effects, so they should be avoided. Please monitor your response after 4 weeks and then 4 weekly until normalization of the hemoglobin. Make sure to replenish your stores by continuing treatment after normalization of parameters for 2 to 3 months. And then note that there will be some patients who fail to respond to oral iron due to either non-compliance, malabsorption, systemic disease, or other issues. And then inadequate response would then demand that we use intravenous iron in these patients. We know that intravenous iron replenishes body iron stores more rapidly than oral iron, but what's interesting is that the HB response is similar, only marginally faster. But settings where IV iron is preferred is those that are failure to respond that we've mentioned already, issues with administration or tolerance or compliance of oral iron replacement or repletion therapy, iron deficiency in the setting of anemia of inflammation, and importantly, as I mentioned, in inflammatory bowel disease, we shouldn't be giving oral iron to patients with active inflammatory bowel disease. This is very irritant to the inflamed bowel, so that's avoided there. Obviously, in patients with malabsorption who cannot absorb the iron, you'd use IV iron as preferred there. Patients with ongoing significant bleeding, and of course, in the preoperative setting where speed is required in terms of picking up your HB before an operation. A little about blood transfusion is mentioned at the end of the guideline, and I think this is just to emphasize, it's been emphasized already, that this is really required to treat iron deficiency anemia. Adaptation due to slowly developing anemia and iron deficiency, which is the course of an iron deficient patient, makes it so that these patients are not usually decompensating early on, and giving them, transfusions could actually be harmful in those patients that have adapted to this slowly developing iron deficiency. IV iron reliably produces clinically meaningful HB response, so that should be the emphasis in patients and not treating iron deficiency with blood transfusion. The amount of elemental iron is minuscule in a packed red cells compared to an optimally dosed intravenous iron infusion, which these days can be given once off, as described in the talks already together. In the patient who is severely symptomatic, it said that you can give transfusion, but in my practice, I can't remember when was the last time that we've had to give someone a blood transfusion for a truly symptomatic iron deficiency. So I'd like to concur with all the speakers that have spoken thus far regarding the fact that patients should be treated with intravenous iron and not blood transfusion. Should you, however, have the need to do blood transfusion, this should be very restrictive and then followed by adequate iron replacement. So blood transfusion should not be used as iron replacement in these patients. And then lastly, but not least, I think the tongue twister that Adele had in the beginning was the question that was posed to me, and that, gastrointestinal or gastroenterological wellness, and the secret to that, where do we actually end? And we can talk into much detail about iron molecules and this and that and a myriad of different diseases, as I've done already. But I think when we go back, and this author, which is a French politician, actually, Jean Saverin, and he wrote a very interesting document called The Physiology of Taste. And he was referred to, despite the fact that he was a politician, a French politician, he had this interest in gastronomy. And many refer to him as a gastrologist. So he wasn't a gastroenterologist, but he was someone that had a keen interest in what we eat and in what becomes of us as a result of what we eat. And the catchphrase in his book, The Physiology of Taste, was, "Tell me what you eat and I'll tell you what you are." And this rings true with regards to iron deficiency as well. And I think I'd like to take the opportunity to end like that and say that we should all think about diet. And I think I've emphasized this in the beginning of this talk. And I think we often underemphasize it in consultation with patients in busy clinics, and spend the moments to talk to your patients, whether affluent or whether in impoverished settings. There's always a means to assist patients with better food choices. And with regards to iron, this rings true as well. Patients will often have a lot of excuses about diet and healthy diets being too expensive. And I think the evidence shows that it's not got to do with cost, but actually the choices that you make with the foods that you eat. And I think this slide is demonstrating this nicely. And for the last part of my discussion, my answer to this is that the secret to gastroenterological wellness is actually within us. And I take that as my learning point for the end of this discussion. And with that, I'd like to thank everyone again for your keen attention, and thank the Inova team and Adele. And then also lastly, before I hand back to Adele, to wish everyone a good December and happy holidays to everyone. We wish you well. Take these points and all these learning, enlightening lectures that you've had with you. And I hope that you have lovely holidays with your families. Eat well, eat healthily, and let's all strive towards this gastroenterological wellness that is actually within us. And I hope I've helped you with that this evening. Thank you very much.
Dr. Simmonds, wow. Once again, thank you so much for sharing this remarkable presentation with us, making us aware of the role of the enterocytes in the regulation of iron. Wow, it's amazing that you try to find out how many there are actually available within our gut, and you couldn't really find, but we all know that there's quite a lot, as well as taking us through the causes of what can cause iron deficiency anemia. And then I think closing off with the important choices we make in what we eat. I'm sure that all dietitians will really agree with you. So it just actually makes our lives so much more simpler if we just look after ourselves and be aware of what we put in our mouths. And often that is sometimes something taken for granted, especially in the difficult and busy times that we are finding ourselves in today. So we do have a couple of questions. I think there's 4 questions at the moment and 5 questions that we can take. I'm not sure whether you do have sight of the questions.
I do have sight of the questions. I don't mind to read them. So
brilliant.
Thank everyone for the keenness and the questions that I see here. So the first one is from Devnan Nana. If a patient is on a PPI, when does the oral iron have to be taken? A very difficult question. So the PPI is suggested to be taken in the morning with your breakfast. So as to inhibit your iron, your acid production from your first meal. So your first meal, actually your thinking of your first meal would then cause you to efflux these PPI pumps in the parietal cell mass in the outlet of the stomach. And the job of the PPI is to inhibit this efflux of these proton pumps. Once you've triggered them, there's little you can do. They remain active for a 24-hour period, and then they go back to sleep or regress, once you recline or retire at night. And then again the next day, these pumps are activated in the morning with your first meal or the thought of your first meal, and hence your PPI should be taken in the morning. That's what we advise patients. The oral iron preparation, then, there's not really a time. So it's not to say that you should use it away from the PPI, because remember that there is also a basal acid output in the stomach, which is a histamine-related basal acid output. So it's not to say that the PPI, for the patient who you are trying to replace iron in, is going to inhibit that iron, short of the patients who are taking PPIs chronically. And if you think about it, there are very few indications for chronic use of PPIs. So majority of PPI indications are for 6 to 8 weeks at a maximum. For the case of H. pylori, you take it for 2 weeks, and then you would be spared the PPI. So when you take the oral iron, when you are on the PPI, it's not really an issue. We really see it as patients who are taking PPIs chronically for something like Barrett's esophagus or hiatus hernia not amenable to surgery, or acid hypersecretory states. And in those patients, you should then preferably take it, away at least 2 to 3 hours away from the PPI dose, once your basal acid output is then able to cater for the conversion of ferric to ferrous in the stomach. But it's not such a big problem for patients who are taking short-term PPIs, which we stress, we think that people are using PPIs too much at the moment and for too long. And I think it just asks of us to review the indications for chronic PPI use in our patients. So I hope that answers the question. Your second question, in a patient with oral iron but no GIT bleeding, can the stool for occult blood be positive? Okay, so I think no. So the tests for occult blood are picking up hemoglobin. As far as I speak to correction, but the occult blood, and especially the newer occult blood tests, as well as the newer FIT or fecal immunohistochemistry tests, are picking up human hemoglobin. So I can't say that oral iron with no GIT bleeding is going to be positive. In the rare occasion that the patient has profound side effects to oral iron, that may be the case if there's some gastrointestinal erosion or something as a result of very high doses of oral iron that ends up in the colon. That may be possible, but not as a direct consequence of the iron itself. But I stand to correction there. Lucky Nokweni is greeting. Good evening, Lucky. Thank you for the greeting. Good evening. And then Agnes Barta, thank you for your question. Patient with normal gastroscopy and colonoscopy and persistent anemia. When and how would one decide to request? All right, so the scintigram, the scintigraphy is interesting. So this would fit, if you remember, I spoke about obscure GIT bleeding, and that would be overt and occult. This would be helpful in a patient with overt GIT bleeding. This is the patient that's exsanguinating, and the key here is the speed of loss. So the scintigraphy that you mentioned needs a minimum speed of loss of at least 0.5 mils per minute to yield an answer or a blush that would tell you where the bleeding is. So, and these patients would present with features of exsanguination and anemia symptomatic long before they presented with iron deficiency. So we wouldn't use the scintigraphy to evaluate a patient with refractory iron deficiency with normal gastroscopy and colonoscopy. That would be the round where we would use a video capsule endoscopy for that patient, following a meticulous relook, upper and lower endoscopy. So I hope that answers that question. Thank you very much for that. Nicholas Veliotes, much appreciated. It's a pleasure. Thank you. And then Nadia Mulder says, if you're saying the PPI activates pumps for 20, deactivates pumps, PPI deactivates the proton pumps for 24 hours. So it's got to be with the bulk of the diurnal activation of the pumps. So once you activate the pumps in the morning, which is normally where they are happening, that's in the morning, that's when you need your PPI to be active. If you give your PPI in the evening, naturally, due to the diurnal variation, your proton pumps are regressing in any case. So the greatest gain for using a PPI is to give it to inhibit the morning activation, and hence given before your breakfast. Great. And then Nadia Muller, thank you for the question again. Many clients have gastritis due to anxiety and rely on PPIs chronically. So it is a major problem in general practice. The duration of action of different PPIs are different. Can one with a shorter duration of action not be better in this case if a patient struggles with iron deficiency? This duration of action, ultimately, I think we view as even though a lot of PPIs are touted to be different in terms of their duration of action and their molecules to be different, I think at the end point they are largely similar. So this is our opinion, and I think we would view PPIs as a group. I know there are certain molecules that have bicarbonate, with higher doses and tend to be touted as better. But yeah, I tend to defer, and I think the shorter duration action in PPIs, I don't think they're better in this case. And like I said, or like I tried to emphasize, I think, as you say, the major problem in general practice, we should all be reviewing our indications in patients. And I don't think gastritis, sorry to say, But gastritis due to anxiety, I don't think that's a proper indication for long-term PPI use. I think we should scope that patient. We should see whether there's H. pylori. We should biopsy and see what the cause of the gastritis is, and we should help the patient in that respect. Giving PPIs for an undiagnosed gastritis for anxiety, probably we need to review that indication. Yeah. So that's my comment there. And then very lastly, Lapale Mopalai, Dr. Wayne, it is my honor to be, former student. Dr. Mopalai, wonderful. This is great. It's great to get a question from you, and I think it's a privilege for me to have a question like this, that I was your student. That's what I understand it as. Yes. There was a teaching about 200 milligram ferrous sulfate TDS with folic acid raising. Yeah, I think, the high dose ferrous sulfate with folic acid, 1 per week, I don't think we concur with that. I think the inhibition at this high level, as I've alluded to, with regards to the sensing of the high percentage of ferrous ion on the basolateral side or on the luminal side of the enterocyte, and the rapid saturation of your transferrin would quickly up your hepcidin and impede transport through your ferroportin channel. So that would give a patient massive amounts of side effects, would give a patient discomfort, and your uptake would be slower, interestingly. So I think the idea these days is to give daily or alternate day dosing with ferrous sulfate. The sucrosomal ions, endosomal ions, I think they are using different modes of entry into the enterocyte and beyond, and they can be then taken daily with much less side effects. So I have to, emphasize the point that these high-dose ferrous sulfate regimens, even though it exists in our EDL books and in many old books that are being used by junior doctors many a time, we should be advising against this and using, if not daily, then every second day, or alternate dosing, in these patients, but certainly not TDS. Thank you very much for the question, and it's a pleasure and an honor on my side to make contact with you again. And I think there's another question. In a patient with hyperemesis gravidarum. So this has been discussed in the sessions, on the pregnancy sessions. So I think I would defer to those sessions on pregnancy here. So hyperemesis gravidarum, obviously, if you're talking about oral iron, that is going to be difficult in these patients. But many of the newer formulations then, are much more tolerable, and I think they should be considered. So the ferrous salts should be avoided in this setting. And again, I think one should try and treat the hyperemesis gravidarum and try and evaluate that, in terms of the cause in pregnancy. And then just keep in mind that in the first trimester, where your intravenous iron is contraindicated or maybe indicated. And I think those points, as alluded to in the previous sessions on pregnancy by Professor Lowe, are crucial with regards to this question as well. What I can emphasize, though, from the gastroenterological side, and what we advise patients on is, and which has been emphasized by the previous sessions also, is making sure that ladies of childbearing age don't start out iron deficient to begin with. And we should use all that we have to counsel patients so that should they venture down this route of pregnancy, you'd be much better off repleting their iron, however you do it, oral or IV, before venturing down pregnancy, so that we don't have to deal with difficult questions like this in pregnancy. But I'd defer question then to the sessions that were dealing with this topic in more detail. But thank you for the question. And that brings us to the end of the questions. Thanks for all the questions, everyone, and much appreciated. And I hope I've been able to answer them appropriately. Thank you, Adele.
Dr. Simmonds, thank you for the calm way that you enhanced our knowledge of iron in gastroenterological wellness and answering all our questions tonight. It's really, really, really appreciated, and I certainly enjoyed your presentation. Then just to wrap up, as I mentioned earlier, the 10 multiple choice questions are available via the link posted in the chat box for those who would like to complete the questionnaire at the moment or now directly after this talk. We will aim to have the supporting module as well as a recording uploaded onto the second link, which will navigate you to the full Iron Masterclass 2024 series of this entire year. So please note that this series is only accredited until the end of December 2024 for a total of 20 CPD points. So if you missed any of the extremely valuable sessions that we had throughout this 10 series, please make sure that you don't miss them and that you do go listen to them and complete your CPD questions. If there's any other queries that you have or any queries that you have with regards to your CPD points, my email address have also been posted in the chat box, so please send all those queries to that one address. It's just easier to navigate all the queries coming into one point of contact. And then on behalf of Inova, thank you to all of our attended guests, not only for tonight, but throughout the entire series. There's been people that's been attending every session throughout this entire year. To the entire Iron Masterclass speaker panel, with Professor Vernon Lowe spearheading this initiative closely with me, a warm thank you from the depth of my heart for making my vision to bring a wealth of knowledge on iron deficiency to healthcare professionals a reality. It's just really appreciative, and I can really say from the bottom of my heart, it's been an absolute pleasure to work with every one of the 5 speakers that participated in the series throughout the year. And then lastly, from Inova Pharmaceuticals, we wish you a joyful festive time and time well spent with your families and a prosperous new year. And we will definitely see you again in 2025, and have a lovely rest of the evening. Good night.
Good night. Thank you very much.